So Carla Gibson is going to join us. Carla is the Vice President of Programs for Reach Healthcare Foundation. Carla?
Thank you, Todd, and thank you everyone for inviting me to be a part of the conference today. I am a RHEC alum, and I'm also a past award recipient for the conference. So it's like coming home, I guess. And I'm really happy to be here. So as Todd said, I am the Vice President of Programs at the Reach Healthcare Foundation. And what my responsibility is to oversee the programmatic aspects of the foundation. And that does include our grant making and our initiatives and all of our community work that we do. So next slide, please. So I'm going to give you a little bit of a background about the Reach Healthcare Foundation. We are a health conversion foundation that was formed out of the sale of the Health Midwest Hospital System in 2003. And out of that sale came two foundations, one on the Missouri side and one on the Kansas side. We are the foundation on the Kansas side, and our sister foundation is the Health Forward Foundation on the Missouri side. We each have the same service area. We invest and serve 3 counties on the Kansas side and 3 on the Missouri side. 3 are rural and 3 are urban. And the ones on the Kansas side are Allen County, Johnson County, and Wyandotte County. And on the Missouri side, it's Cass, Jackson, and Lafayette. And we do serve a portion of the Northland, which is the city of Kansas City, Missouri. So all of our dollars are required to be invested in those areas in our bi-state region. We invest about $5 million a year, and last year it was $4.4 million invested in grants, and a lot of those grants did involve some level of social determinants of health. And since our inception in 2005, we have invested $6.5 million in our community. I will draw your attention to our mission. It is to advance health equity through coverage, which is insurance coverage and care for underserved people in our region. So I think if you kind of look at who Reach Healthcare Foundation is, it is not obvious that we invest in social determinants of health, but I will walk you through how we do address that, because we could not do our work and meet our goals, our vision and our mission without investing in social determinants of health. Next slide, please. So I gave a definition of what social determinants of health are. I know you all probably already know this, but what is interesting about this particular slide is that it's the last sentence on the slide, that these circumstances are shaped by the distribution of money, power, and resources at global, national, and local levels. So foundations and funders play a critical role in the work in funding the work that you all do in social determinants of health. And if we are not looking at, considering, addressing, and investing in social determinants of health, then we literally are not able to meet our goal. So we are critical in the aspect of addressing them. Next slide, please. So it is important for health philanthropy to fund social determinants of health for many reasons, but the ones that I listed here, you will see those words in all of our like long-term goals, any of our communication, We are all about increasing health equity, decreasing health disparity, and improving health outcomes. And those are all of the things that are really important in addressing social determinants of health. I wanted to give you a example of the different types of foundations that, a sampling of the different types of foundations that invest in social determinants of health. You will find that there are single focus foundations that is all that they do, that they are set up and they exist just to fund in one particular area of social determinants. And I did list an example, which is the NEA Foundation, and they only invest in education. And then I will also point out that I do have a typo on my slide, and I do apologize for that on the next section, which are primary focus foundations. Those are foundations that are focused in one and more areas of social determinants of health. And so locally here, the Kauffman Foundation, while they fund in many areas, they are largely known for funding in education and entrepreneurship. And then we have your health funders, who we cannot meet our long-term goals without addressing social determinants of health. And an example of that is the Colorado Health Foundation, Reach Healthcare Foundation, and the Health Forward Foundation here locally. Next slide, please. So I'm going to kind of walk you through our approach to funding. These are our guiding principles, and we don't do such a good job in always sharing these. I know we share them internally, but we don't share them externally very often, but these actually drive all of our grant making. And I will let you kind of read those, but the one at the end, the funding one, that is really talking about funding change and not just need. We as a foundation cannot fund change if we don't fund or invest in work around social determinants of health. And so, while once again not critically obvious of what we do, we are very much committed to our approach being that of social determinants of health. So next slide, please. This is where I'm going to point out how we actually do invest in them. This year concludes our 5-year strategic plan. We have decided to not go into a full-blown strategic plan, another full-blown strategic 2-year plan. We are going to spend the next 2 years really researching and developing what to invest in our next big plan. We do, with this strategic plan, hold ourselves accountable to an actual target goal. And we are going to, we have adapted our target to protect the gains that we made in lowering the uninsurance rate. And we know that our grant making is not the sole cause of the uninsurance rate decreasing, but what we feel is that all of our investment, if we invest right, will contribute to reducing the uninsurance rate in our service area. Our work is guided by what we call a community investment framework, and that's this document that you see with the arrows on it. And these strategies are where that's actually our grant making. That's the things that we invest in. We have identified 3 outcome investment areas that are kind of like the larger buckets that we invest in, and they are enroll all eligible, close the coverage gap, and strong safety net. The outcome, the social determinants, while not obvious, but we have strategically embedded them in our work. And I will turn your attention to some examples of where we really do address social determinants of health. So if you look under the outcome investment area of enrolling all eligible, which is ensuring that people are getting the coverage that they need, we invest in navigators and other assisters to help people access public benefits programs. And those public benefit programs are SNAP, unemployment, Medicare, Medicaid, literally any public benefit program that someone is eligible for. We invest in those positions that enroll people in care and coverage. And so while it's not just healthcare related, but it's very much contributing to healthcare, ensuring that all the determinants are addressed and not just healthcare. Under the outcome investment area, close the coverage gap, which is largely our investment around Medicaid expansion. But the number 3 bullet is around building leadership and partnerships to create coverage for those who are historically underserved. That is where our investments in immigrant health and communities of color and really research. We put out a lot of research related to informing our community around the things that impact immigrant health, the things that are impacting Medicaid expansion, making the case for Medicaid expansion. That is all under our investment area number 3. And strong safety net, I would say all of those bullets are really addressing the social determinants of health. We've provided about $1.4 million of core operating support to our area of federally qualified health centers, community mental health centers, and advocacy organizations. And that is unrestricted funds to support the operations of those organizations. And it is renewable every year, and we support 29 organizations under that strategy. The second one is, I think the investment in social determinants of health is obvious, but I will pull out that we really do a lot of work in trauma-informed care and really addressing the impacts of toxic stress and historical racism and supporting trauma as it relates to our community. And then number 3 is really a significant investment of ours. That is where we invest in community health workers, care coordinators, and any position that links the consumer to healthcare services. But those positions don't just link people, they address and remove all of the barriers that might exist for that consumer to connect to healthcare. And so right there then and of itself is they're addressing housing, they're addressing food insecurity, they're addressing transportation barriers. And so we have heavily invested in that area, and that is a signature investment of ours, and we will continue to do that in the foreseeable future. With this last strategic plan, we also have actually identified priority populations, and they're listed on the screen in front of you, but I will just say these populations we know, no matter if Medicaid is expanded, no matter what, will always need our support. And our support is not just restricted to providing health care for them, but it's also removing any barriers that these populations might have. And so our investments are often not just healthcare related in these populations. We have had to really look at housing. We have had to invest in things that traditional healthcare foundation might not invest in. But because we have identified these populations as priorities for our funding, we are really looking at funding differently to address the need no matter what for the undocumented, for youth transitioning out of foster care, and for the homeless population. Next slide, please. So Todd also wanted me to address how we might have responded during the COVID, during our current COVID process. And I will say that we did 3 things that have enabled our grantees to maybe be able to address social determinants of health a little bit better. One of the things that we did was deploy over $1.5 million out to our federally qualified health centers and our community health centers in the form of unrestricted dollars. We gave all of our core partners an unrestricted grant to do whatever they needed to do with. And there was no questions asked. There was no, not much paperwork, and it was theirs to shore up their operations so that they can actually serve their clients better. We also went in and unrestricted current grants that we were giving out. So while the grant might have been for something very specific, we allowed our grantees to unrestrict them to address whatever need that they needed at the time during COVID. And many of them shifted to food distribution and transportation, and actually reaching out into the community to find those most in need. And then the other thing that we did was we invested a significant grant award in the Regional COVID Response and Recovery Fund. And that fund is actually set up to address any response need or any recovery need for a large number of grantees in our service area. So we provided some support for that fund. And I actually serve on it, and we are currently looking at housing, public health, and digital equity, and out of school support for our community. So that's all that I have. I want to thank everyone for listening, but I did want to say it's gone now, but I wanted to leave my contact information in case anyone had any questions for me.
Thanks, Carla. We can post it back and we can make sure we put it in the.
So thank you, everyone.
Okay. Thanks, Carla. We'll make sure we put that in the chat box as well, or you can place it in the chat box if you like. Our next speaker is Greg Donovan. He's the director of the Society of Care. And I really want you guys to pay attention to Greg. Greg is going to give you some really, really new information. I don't think we know enough about the work that the good work that he's done, the quality work he's done up in his region. Greg.
Thanks, Todd. And I did have slides. Are they going to be shared? Thane? Thank you. As Todd mentioned, I'm the director of the Society of Care. We work with Native young people and communities in Nebraska with a behavioral health lens. One of the things we found as we've pursued our work is that it's impossible to pursue behavioral health and wellness without looking at social determinants of health. That we, in addition to licensed behavioral health providers and traditional care providers, have outreach specialists, navigators in each community, and have found that a significant portion of their time is focused on helping families and young people address needs around things like transportation, food, shelter, and the like. And so that's where we get started. We are part of the Santee Sioux Nation. and through the grace of the tribal council and the leadership are able to work alongside any self-identified Native individual within the state of Nebraska. Next slide. As we get started, just a quick snapshot of what the Native American population looks like in Nebraska. It's about a little bit over 31,000 individuals. While a small number and a small percentage of the total population, it is disproportionately influential in social determinants of health and sort of social welfare indicators, that moving the needle in assisting the Native population moves the needle for the whole state, which is bizarre given how small the population is. As you can see, the population is roughly divided evenly between rural or frontier and urban and reservation communities. Next slide. One of the things that's intriguing is that we do focus on young people, and that population is growing within Nebraska. And that contrasts with a bunch of other states, over half, 26, that have seen negative change amongst that population. Next slide. Another intriguing dynamic that speaks to sort of the family composition and the within Native families and Native communities in Nebraska is on the left. The population pyramid for the whole state is roughly what you would expect. It looks like a pyramid. On the right, you can see that it looks more like an apple core in some ways that's been had a bite taken out of it, with a lower percentage of youth and young adults than expected. And that to some degree reflects the number of grandparents caring for their grandchildren, but to some degree we're still trying to undermine and figure out the true causes of that. Next slide, please. As we look at care, there are a variety of things that impede our work and impede the work of those trying to assist Native Americans in Nebraska. These include mistrust. There's a long legacy of dishonest dealing by governmental entities, by those seeking to engage Native communities, and that's created a legacy of mistrust. As with many communities, the whole realm of mental or behavioral health brings with it stigma. This is compounded by the fact that there's a lack of cultural understanding, and that even when people try to be culturally aware, oftentimes they speak of Native peoples, not recognizing the unique dynamics of each community and each tribe. And then this is a reality for a lot of Nebraskans, is that the vast majority, something like all but 3 of the counties in the state, are defined as behavioral health deserts with an insufficient number of providers. And this is obviously exacerbated when you look at those that are actually culturally informed and aware. And then the final thing which we work to overcome is that because so many of the Native relatives we work alongside are low income, that cost can be a significant barrier to accessing care. Next slide. Contrasting the barriers, there are a number of unique protective factors that we have found in working with Native peoples. Foremost amongst them is a strong tie to their culture. This is especially prevalent in reservation communities, but also in urban and rural areas. One of the dangers, though, of assimilation or the pressure to assimilate in rural and urban communities is sort of a divorcing from their culture and a divorcing from the customs that have brought strength for generations. There tends to be a very strong bond with family, a strong connection to history, and a reverence for the past. A number of traditional health practices are continued and have proven over generations to be valid and valuable. Native peoples have also shown amazing adaptability in ranging from the forced marches to current situations with changing settings and things. There's a deep respect for elders, and to some degree that includes intergenerational transfer of customs and the like, and a strong belief in the Creator and a spiritual orientation. Obviously, these are broad generalizations, but they are things that we have found to be prevalent. Next slide. About us, I mentioned that we're intertribal and multi-tribal. We focus primarily on young self-identified Native Americans, but recognize they exist within a family setting, and so work very closely with their caregivers to strengthen their capacities. Similarly, we recognize that we all operate within a larger society, and so we work with key strategic stakeholders throughout the state to enhance behavioral health, the quality of life, and systemic change that benefit youth, families, and Native communities. Next thing. As I mentioned, it's statewide. The Santee Sioux, Omaha Tribe, Winnebago Tribe reservations, the cities of Omaha and Lincoln, and then the rural and frontier communities in the Nebraska Panhandle, where there's a strong representation of members of the tribes from South Dakota and kind of a migratory pattern between those reservations in South Dakota and the Nebraska Panhandle. Next slide. In reaching out, we started with an approach on counseling, both in person and through telehealth. With COVID limitations, recently it's been exclusively through telehealth, but we've realized that to reach out, we needed to provide education and then some of the services I mentioned in terms of guidance in meeting basic needs and understanding some of the underlying dynamics behind some of the issues that we see in counseling, and have done so. We also advocate, as I mentioned, and work with stakeholders to bring about systemic change. In our work, we go sort of beyond being trauma aware. Our team is trained in trauma approaches, trauma-informed approaches. We also focus a lot on suicide prevention, as the Native population in Nebraska has a rate of suicide attempt and completion that is dramatically higher than the general population. The same is true for substance use, and so substance misuse is something we focus on. We also focus a lot on those young people, 16 to 25, in the transitional years from adolescence to adulthood. That's kind of the direct service approach. We also realize that both because the numbers are small and also because there just is limited capacity, that a lot, it remains unknown about Native peoples. And it's hard to develop longitudinal studies or trend analyses or to plot effective solutions. And so we work to fill in the gaps around research. In moving ahead, one of the key things that allows us to be successful is that our team members are of the communities they assist, that we have strong connections to communities. We've been very cautious in marketing ourselves to those communities because there's been so many efforts that have flown at Native communities saying they're going to solve all the problems and then disappear. We work alongside those that we assist. In saying that, we also are incredibly highly skilled. I have no hesitancy to brag about our team because they are incredibly accomplished. The behavioral health providers are licensed and trained in models that serve the population of focus. Our whole team is culturally aware. And as we go about our work, we enthusiastically look for opportunities to collaborate. In doing that, as I mentioned, we approach our work with passion, with humility, with an appreciation for the cultural uniqueness of each young person and family, with respect and understanding for their situation, and in general, try to under-promise and over-deliver because there's such a series or history of disappointment amongst those with whom we work. In reflecting upon the ideas that we are sort of all in this together and that we're interconnected, we consciously refer to ourselves as a society, not a system, and look at those that we work alongside as relatives, not clients. In doing so, we recognize the impact of trauma, both historical or intergenerational trauma that ranges from things like forced marches and relocation to the boarding school experiences where the sort of save the individual, kill the Indian thinking that led to that a number of current grandparents experienced when they were young. The legacy of that has been shown to be present even in young people today, as well as the trauma of some of the challenges posed by the issues that we talked about regarding social determinants of health. Contrasting trauma, the people we work alongside have demonstrated amazing resilience in sort of thriving despite all of the challenges they face and managing even to wake up in the morning and function in a productive way. We also work to reinforce aspirational thinking amongst Native young peoples, that the unemployment rate is dramatically higher for Native peoples in Nebraska. The number of disconnected youth is also dramatically higher. The disconnected youth being those teenagers largely who are neither in school nor employed. And so we create opportunities for them to think and to explore potential that is a brighter future for them. In doing so, we respect science and evidence-based practices. Things like trauma-focused cognitive behavioral therapy are used by our team. We also deeply respect practice-based evidence, things that for generations have shown efficacy in bringing about wellness, like talking circles, sweat lodges, and other cultural interventions. As we move ahead, we're looking to sort of unite everything I talked about under an umbrella called the Nebraska Native Trauma and Research Consortium, which again unites us in caring deeply, transforming lives, and healing communities. And that's me and our Facebook page. So thank you all again. I'm really excited by the energy today, by the rebirth kind of our HEC and the opportunity to be engaged. And I hope that what I shared is helpful and that there are opportunities for us to work together moving ahead. Thank you.
Thank you, Greg.